So we've made a lot of headway with the treatment of Ph-positive ALL, and one of the aspects that has been most important is the early use of tyrosine kinase inhibitors in the frontline therapy and also as part of induction. And actually I showed data that we generated about 10 years ago on a comparison of Imatinib as the only then available kinase inhibitor versus chemotherapy, and we showed that the kinase inhibitor alone was superior to what was then standard chemotherapy in that practically every patient achieved a complete remission, twice the proportion as in the chemotherapy arm, and that the tolerability was far better. And there have been more recent studies that also looked at kinase inhibitors frontline in combination with different intensities of chemotherapy, and it has become evident that the induction treatment actually can essentially eliminate or substantially reduce the chemotherapy intensity and rely on the kinase inhibitor without long-term adverse effects. So that was the first part. The second is that in the post-remission therapy, we are still not doing well enough with kinase inhibitors plus chemotherapy, irrespective of the intensity. This is especially true of the first and second generation kinase inhibitors, with a possible change with third generation Ponatinib, although there's only one trial to show this. So for that reason, stem cell transplant as a very aggressive, intensive treatment is still a mainstay in younger patients, but the goal is to reduce it and to identify patients who will actually not need it. For example, those that have had a very good molecular response to frontline induction therapy.